Dear doctors, today our topic is congestive heart failure. In congestive heart failure, our heart may not be able to pump deoxygenated blood towards the lungs, or it may not be able to pump oxygenated blood towards systemic circulation. It means congestive heart failure should be divided into left-sided heart failure and right-sided heart failure. In left-sided heart failure, patient won't be able to pump oxygenated blood towards systemic circulation, while in right-sided heart failure, patient won't be able to receive the deoxygenated blood flow from the venous circulation towards the lungs. First, we are going to talk about left-sided heart failure, and we are going to start from causes. You people better know that where is our left-sided heart and where is our right-sided heart. So basically over here we have got left atrium and left ventricle. This left atrium plus left ventricle will actually form our left heart, while our right atrium here and right ventricle will form our right-sided heart. So whenever we say left-sided heart failure, it means something is wrong with our left ventricle. So specifically we are talking about left ventricular failure. Now let's talk about the causes that can contribute to left-sided heart failure. The causes are myocardial infarction, hypertension and cardiomyopathies. Since the USMLE exams and other most international standard exam are no more memorizing exams, right? So we are basically relying on concepts. So we are basically going to talk about the mechanism behind these causes that contribute to left-sided heart failure. We will take one cause, right, and we'll explain the underlying pathophysiology that actually contributes to left-sided heart failure. So let's talk about hypertension. Remember that in chronic hypertension, afterload is increased. So if afterload is increased due to chronic hypertension, left ventricle has to generate a lot of pressure to counteract this increased pressure that it is actually pumping against. In very simple words, we can say that since in chronic hypertension afterload is increased, means left ventricle has to generate a lot of pressure to counteract this already generated pressure. That's why left ventricle has to do what? Hypertrophy. In order to meet that increased pressure due to increased afterload, which is basically increased pressure, right, generated by chronic hypertension, left ventricle has to do hypertrophy. Now remember that hypertrophy has got two types: concentric hypertrophy, eccentric hypertrophy. Whenever we talk about hypertrophy, it has to be either concentric hypertrophy or eccentric hypertrophy. When we say concentric hypertrophy, the smooth muscles that are added over here is, in parallel shape. It means the left ventricular cavity is decreased. So the smooth muscles are formed over here, right? So we have got a very, very small cavity inside left ventricle. This is called concentric hypertrophy. So technically, how can we define concentric hypertrophy? We say that when smooth muscles are added to the left ventricle in a parallel patient, we call it concentric hypertrophy. The hallmark of concentric hypertrophy is decreased left ventricular cavity. Contrastly, when we say eccentric hypertrophy, the smooth muscles are added in series. So it means eccentric hypertrophy, the left ventricular cavity is getting increased. It means the smooth muscles are added in series like fashion. Suppose this is your aorta. So in aorta, pressure is increased, means the afterload is increased. Due to this increased afterload, left ventricle has to generate a lot of pressure. How will the left ventricle be able to generate more and more pressure? It has to undergo hypertrophy. It has to undergo specifically concentric hypertrophy. In concentric hypertrophy, smooth muscles are added in parallel fashion. It means the inner left ventricular cavity is decreased. Eventually, this hypertrophy will be converted into dilation if this chronic hypertension is not treated. This dilation will eventually contribute to failure. Now, if we people talk about cardiomyopathies, if we talk about hypertrophic cardiomyopathy, it will be concentric hypertrophy. If we talk about dilated cardiomyopathy, it will be eccentric hypertrophy. Dear doctors, in your books, it's mentioned that when we talk about clinical features related with congestive heart failure, first clinical feature that you people can come across is pulmonary edema. Now, you people might ask that what's the underlying pathophysiology behind pulmonary edema. In order to understand pulmonary edema, first of all, you people have to understand that in left-sided heart failure, left ventricle can no more pump blood out of the left ventricle towards the systemic circulation. Since your left-sided heart wasn't able to pump blood towards the systemic circulation, so there will be backflow of the blood from left ventricle to left atrium. The blood from the left atrium will go towards pulmonary veins. Since lots and lots of blood has come from left side towards pulmonary circulation over here, so you people will see that there will be congestion. First of all, there will be congestion seen in pulmonary circulation, right? Since the pulmonary circulation is now congested, right, the blood will eventually leak out. Means we can say that hydrostatic pressure in pulmonary circulation will be increased. This increased hydrostatic pressure actually contributes to pulmonary edema. Now, due to pulmonary edema, patient will be having shortness of breath. Now we are going to talk about a very important topic called cardiac remodeling. Remember that in left-sided heart failure, since your cardiac output goes down, it means the renal blood flow goes down. As the renal blood flow goes down, a system called RAS is activated. There is vasoconstriction, which actually increases your blood pressure. That's one point in cardiac remodeling. And second, we had a lot of aldosterone, and that aldosterone actually contributed to increased sodium and water reabsorption. Hence, fluid overload is more precipitated, because in a patient with left-sided heart failure, you people better know that fluid is already overloaded. So this RAS further precipitates this condition. Let's talk about right-sided heart failure. Remember that most of the times, right-sided heart failure is due to left-sided heart failure. Jugular venous distension, cardiac cirrhosis, and lower limb edema has got its specific pathophysiology. So let's talk about jugular venous distension, which is a clinical feature seen in right-sided heart failure. Your SVC, superior vena cava, is actually draining the deoxygenated blood into right atrium. Whenever you people have got failed right heart, so it means the right ventricle cannot push the blood towards lungs. It means the blood that wasn't pumped towards pulmonary circulation will actually backflow back into right atrium. From right atrium, this blood will be transported back to superior vena cava. Hence, you people can now get that why the jugular veins are distended. Then we talk about cardiac cirrhosis. So to understand the basic pathophysiology behind cardiac cirrhosis, you people have to recall that hepatic vein actually drains into IVC, inferior vena cava, and this inferior vena cava then drains into right atrium. Since patient has got right-sided heart failure, blood will be flowing back from right atrium to IVC, and then from IVC it will be going back towards hepatic vein. When more and more blood reaches towards hepatic vein, we will see hepatic congestion. After hepatic congestion, there will be liver cirrhosis. But this liver cirrhosis is called cardiac cirrhosis.